Hello, everyone. Welcome to our Unit 5 discussion here in ST 125. This week we are covering the topics of endoscopic instrumentation. So here are our objectives for this week. We're going to be talking about different types of endoscopic equipment, the categories of endoscopy, what that entails, because it's kind of a broad term, to be honest. And we're going to talk a little bit about how to process some of those instruments as well. So what is endoscopic surgery? So a lot of this, if you just use your med term, you're going to get a lot of this. Okay. So if you haven't had med term yet, I'll break it down for you, but you definitely need to be reviewing your medical terminology, because even if you haven't seen something, but maybe you know what it's called, it'll clue you in as to what it's used for. Okay. So endo means inside or within. Um, this little suffix here, ic means pertaining to. Anything scope is like to view. So pertaining to inside viewing is literally how it's translated, but to view inside the body. So that can happen in a lot of ways. We could use a natural orifice in the body. Maybe we go through the nose, the ear, the mouth. All of those are already there, so they're pretty easy access for viewing inside the body for certain parts. Or we can make incisions, let's say in the abdomen or in a joint like a knee or a hip or a elbow, shoulder, any joint really, to view inside that joint, see what's going on. Those are all types of minimally invasive surgery. We make small incisions for quicker recovery time. Um, Patients typically get to go home the same day, usually, not always, but usually. So it's really becoming quite prevalent to do as many cases as we can minimally invasive. It's just better for the patient, better outcomes. Now, that isn't possible with every single surgery, but we're coming a long way, especially with robotics, being able to do what used to be a strictly open procedure with big incisions down to robotic surgery. So that comes with a whole new set of equipment when we change from open to scopes. All right. So you have to have completely different setups, different like towers of equipment, different types of power for supplies. Okay, so that's what we're going to be talking about today. So pictured here, this is a laparoscope. So lapar means abdomen. So this type of scope is used to view inside the abdomen. So this is your typical scope, okay? Most scopes to view inside the abdomen that are not like going down the throat or something looks similar to this, okay? Now, if you need to view, let's say the sinus, right? We don't have to go very far. So those cameras or scopes are much shorter and much smaller, thinner, less diameter. So, I mean, you're just going to change based on the area that you're working on, but the concept stays the same, okay? There's always something here for a light cord adapter that will have a special cord, a light cord that goes between this scope to illuminate it to a tower or a piece of equipment, a box that you hook up to that will have the light source. Okay, this end here is the viewing part. Now you could just stick your eyeball on it and see down the scope. Now I've had some old school cystoscopy doctors, cystodocs, that would do that. Okay. Then you can't see on the screen as a search tech what's happening. But anymore, we will have a like camera head adapter that fits on the end of this that also has a cord that goes to the box to project the picture. And this is just a typical scope, or a trocar, I should say. That's a scope. This is a trocar. This is a blunt trocar because there isn't a blade or sharp part on the end of it. There are tons of different types of trocars depending on surgeon preference, where you're at, patient size, a lot of different things. Okay, so the trocars are basically the same. I think I have another one on the next page, but there's always a valve here that you can hook up to insufflation or gas. You can open and close it to control the flow of gas. This middle part that's got that white sticking at the bottom is called an obturator. So that helps put the trocar in. The black would stay in place once you made your incision and pushed it through the layers of tissue. And then the surgeon will pull out the white middle part that is called the obturator. Never get rid of the obturator ever. Okay, if you're scrubbing in as a surge tech, keep that on your back table, okay? Because if this whole thing comes out, which happens, it slides out or gets pulled out, they'll need that middle obturator to help put that back in, okay? So endoscopic surgery. Basically, you're just changing the med term on the front of this to dictate different types of viewing, different types of scopes, procedures, okay? Oscopies are all, notice, by the way, it is pronounced oscopy, not scopy, okay? That is a common thing among students that they mispronounce it, but if you pronounce it right, they're gonna have a little bit more confidence in you that you know what you're talking about. So cystoscopy, laparoscopy, okay, not scopy. So cystoscopy would be to view inside the bladder. So is bladder. Laparoscopy, lapar is abdomen, very common procedure in GYN as well as general surgery. Thoracoscopy, the thorax or the chest. Laryngoscopy would be looking at the voice box or the larynx. FES stands for functional endoscopic sinus surgery. So a small scope that we can view into the sinus cavity. Now this one's a little odd because it's got this vowel in the middle of the eye. It's pronounced pelviscopy, okay? Pelviscopy. So it is a little confusing. To view inside the pelvis, it's just a smaller, lower incision. Hysteroscopy to view inside the uterus. Arthroscopy is inside a joint, arthur is joint. And then endoscopic spine surgery is becoming pretty popular as well, okay? So here's a type of cystoscope, could also actually be a hysteroscope, very similar setup, but notice the same type of scope part that I showed you on the previous page. It's got the light adapter. This part's for viewing at the end, the black part. Now this one also has what's called a bridge. So it connects to the sheath, the outer sheath, but it has ports for hooking up fluid. You have to have a distension medium of fluid. And it also has a port for, let's say you need to take a biopsy. You have to thread a little biopsy needle in there. You can open and close that biopsy needle, pull it back out through that port, and you've got a specimen, okay? So that hooks up to the bridge. This is kind of how it looks all put together with the extra cord. So that gray at the top is the light cord. It's kind of hard to see, but that black part is the camera head cord that goes for the picture. This clear tubing is for a fluid of distension medium of some sort. Okay, so here are your trocar parts. So like I mentioned before, they all basically have about the same thing. There are a few unique things to each of them. I will point out that obturator is spelled wrong in this picture. I do know that it is OBT, obturator with a T. Otherwise, I just wanted to point that out to you. So the obturator is that middle part that usually is a little bit rounded at the end. But this one, inside the tip, it's kind of hard to see, is a blade. So as this obturator and sheath gets pushed through the layers of tissue, probably in the abdomen, this is an abdominal trocar, it will cut through the tissue. Now that first one I showed you was a blunt trocar. That means it did not have that blade at the end of it. So that kind of changes how the surgeon would place the trocar. If it's blunt, they're going to have to cut through more layers of tissue to get into the abdominal cavity. So this one's a little different in that it has a suture tying post. You can put a suture around this, pass it through the skin or subcu tissue to anchor it. That keeps it from getting pulled out. It just kind of stays placed, which is nice. Insufflation stopcock, you could kind of see on the other picture as well. So that's where your gas tubing or your insufflation tubing would hook up to. That would flow into the trocar and then into the abdomen to distend it. Makes it look like you got a really big belly. That way we can see what we're doing inside. So usually our insufflation gas is carbon dioxide. So I just wanted to point those out to you. So you just change the lever position to open or close. Now, I did put this little remember here. Trocar valves, this insufflation valve right here, oops, let me go back, should be sterilized in an open position because some of these are not plastic. Some trocars are still metal and reprocessable. Make sure that they're sterilized in an open position. That stopcock valve has to be open so gas or whatever sterilant can flow through it and down into that trocar. Okay. And even the manufacturer, they have to make sure it's sterilized open as well. So if I get one as a surge tech on my field that was sterilized closed, I have to get rid of it. It can't be used. That means the sterilant didn't go through that trocar completely. So always watch for that. Okay. That's very important. So if you are the surge tech and are now setting up for this case, you check for that. If it was sterilized open like it should be, I go ahead and then close it at that point. Okay. I like to put them up on my Mayo stand in a closed position for that surgeon. So if you're placing one after we've put gas in the abdomen, gas doesn't escape out that tubing hole. Okay. Otherwise, it's just like popping a balloon, so to speak. So if it's closed, that gas cannot escape through that valve. All right, a couple instruments here, laparoscopic, specifically laparoscopic, so abdomen. I just point out here that a lot of laparoscopic instruments have an open counterpart. So, for example, a Babcock. There is a laparoscopic version of a Babcock. I think of a couple others. You know, they're just going to look very similar. Now, these are some exceptions to the rule. We don't typically, at least not to my knowledge, have an open version of a Maryland. There's something that looks similar. I mean, it looks very similar to maybe what a hemostat or a Kelly might look like, but we call it a Maryland dissector. So yes, you can grasp with it. It's got that nice grasping serrations to it, I guess you could say, but it's also really good for, you put those little teeth, not teeth really, but the ends inside a tight space. And what they're going to do is actually open up the ends of those dissectors. So they're spreading them open to get through tissue. We call that blunt dissection. So you don't have to use scissors to get through or push through tissue. You can use a Maryland dissector. Now this is a blunt grasper. This is kind of generic name. I think there might be other names for this in other parts of the country. We just call it a blunt grasper. So it has no teeth, but it's just used for just general grasping inside the abdomen. And then this over here, it is similar and could really be used kind of in similar fashions, is the atraumatic Davis and Geck. So these are not teeth. If you look closely, they're just kind of serrations, maybe a little more grabby than this blunt grasper, depending on what you're trying to do. But, and we have a surgeon around here. So I'm from West Virginia. Really, we're right on the border of West Virginia and Ohio. So we have a surgeon that will call this the West Virginia grasper because it doesn't have teeth. And then we have one that does have teeth on the end, and it's called an Ohio grasper because it has teeth. So just a fun little, we can joke about it because we're from here. So. Laparoscopic supplies. So along with your basic instruments that you have for your laparoscopic cases, you have some other typically disposable items, not always, like for example, this one here is not. But like I said at the beginning, there's a lot of extra supplies that go with any type of scope case because you're going to have to be able to see inside. So you have to have gas tubing or fluid tubing. You have cameras that require special treatment. So you have extra supplies for that. So this cord right here is the insufflation or the gas tubing. There's a couple varieties depending on your company that look similar, but this is gas tubing, CO2. This is what we call FRED or anti-fog solution, whatever you want to call it. FRED stands for, it actually is an acronym, F-R-E-D, Fog Reduction Elimination Device. I think that's been a certification question before, so keep note of that. Fog Reduction Elimination Device. Now, if you're scrubbing in, this is a countable item. Depending on your facility, it could be 2 pieces or 3. I've seen it both ways. The pad, the bottle itself, and the cap can be a 3rd piece. So what you do is you squirt a little bit of the solution on the green pad, which has a sticky backing, and then you can rub this little sponge on the end of one of your scopes prior to the case ever starting. So that kind of creates a little film over the end of that scope that helps prevent it from fogging up when that scope enters inside the abdomen. So think about it. The OR is very cold, usually, right? And then you're going to put this scope inside of a warm body. What typically happens? If you ever go like inside, if you have glasses on, if you walk outside and it's steamy out, you came from inside a cold house, your glasses fog up, right? Same concept. So we want to eliminate that because the surgeons really do need to see what they're doing, and they don't want to wait around for that to adjust temperature wise. So that eliminates that. There's other ways to do it. There's one called a mouse house where you put the scope in and warm it up, a scope warmer. This is a Very's needle or a VersaStep Very's needle. This little stopcock here is what your gas tubing can hook up to, and this would puncture through the layers of the abdomen, through the fascia, peritoneum, as you're pulling up on those, you and your assistant and the surgeon, to put gas inside the abdomen. Then this does not get thrown away. This is the light cord that I showed you got hooked up to that laparoscope. This is the part that gets hooked up to the scope, and the long end is the part that gets passed off to the circulator in the surgery and gets plugged into the machine to provide light. Some other supplies, again, they're going to be open as an as needed basis. You're not going to do the same thing in every case, even if it's scheduled the same way. Okay, not everyone's anatomy is the same. So some of these you really should just wait before you open them if you're scrubbing in. But if you're pulling these cases in sterile processing, you're going to see these probably pulled very often. Maybe not, depends on what you're trying to do. Okay. But if you're doing laparoscopic abdominal cases, these two are very common. So this first one is called an endo catch bag. So it's hard to see, but if you were to push this through this outer sheath, a plastic bag would come out the end of it. That allows you to retrieve specimen. So let's say we take the appendix out laparoscopically. We can't obviously leave it in there. It's got to come out somehow. So we can drop it with like our Davison Geck into that bag, draw that bag tight, and pull it out through one of the trocar holes. That way we have our specimen. So if you're ever removing anything laparoscopically, you might need something like this. Now this one, the second one here is called an endo-GIA. GIA is usually a gastric anastomosis type of stapler. The refills are typically separate. There's different sizes of refills that go on the end of this. It's not pictured because you need to get the right size staple that the surgeon wants. So we always ask what the surgeon needs. But at the end of the case, this gets thrown away. This third one is called a Zumi, Z-U-M-I. This is used in laparoscopic cases when we are doing something GYN related. Let's say we're looking at the tubes and ovaries through the scope in the abdomen, but maybe we need to see behind the uterus. So what we can do is put this in through the cervix and into the uterus, and then someone can kind of manipulate, we call it manipulating the uterus. So if you push down while this is in place inside the uterus, you push that down, it's going to elevate the uterus if you're looking at it inside the belly. So if we need to see behind or kind of rotate the uterus from side to side during a scope case, they're going to want something like this in place. Now this fourth one over here is an endoscopic stapler. So it's kind of hard to see, but there's a little staple end here. The whole thing is disposable. So if you run out of staples, you need a whole new one. Okay. Forget how many are loaded in here. But instead of maybe suturing every little bleeder, sometimes they'll clip them. A lot of clipping. All right, so moving on to endoscope. So like I said at the beginning, the term endoscope is kind of a broad generic term. Endo means to within, to view within. Okay, but sometimes a lot of people will refer to endoscopes as a scope that is going to view inside the intestine. Endo can also mean intestine. So we have scopes like this is pictured here that either go in through the mouth, esophagus, and stomach for an EGD, or we have scopes that will go up the bottom side through the colon for a colonoscopy. So that's what this is referring to. Your EGD scope, which is esophagogastroduodenoscopy, duodenoscopy, or colonoscopies. So they need to be treated a certain way because they're very delicate. They are very expensive, and we want to make sure they're cleaned properly for the next patient. So here are the steps to cleaning an endoscope, and most places will have this written and probably laminated step by step on the wall right next to where you're going to be doing this. It could be in your decontam room. We have a couple places I know around us have an entire scope part of the OR where it's just scopes. So they have their own special room where they clean their endoscopes. They don't always go down to decontam. So you always wipe down the outside, get either, we actually, and your surge tech should be doing this, wiping the outside, at least with a 4x4 or something in the OR at the point of use before ever sending it to be cleaned, in the decontam type area. So always clean at the point of use. You're going to flush the channels, aspirate the water through the biopsy channel. Like I pointed out, a lot of these have a biopsy channel. Tissue can get stuck in those, so for sure, make sure you're aspirating those. Perform a leak test to make sure, because the surgeon is going to be aspirating with fluid, they're going to be using suction. All of that has to have like a good closed system for that suction to work. Dismantle detachable parts, like maybe a light cord adapter. Sometimes there's little rubber buttons that have to come out. Manually clean with a detergent, following by a rinse. And then some places will use an automatic reprocessor, like the Steris machine. And then always check your IFUs for sure, because some scopes or some facilities use glutaraldehyde and some use parasitic acid through the Steris machine. So those are the two probably most common, I believe. Your facility will probably use one of those two. So if you have any questions on any of this or anything, coming up, any of your assignments, please don't hesitate to reach out to me. My email is mludwig@herzing.edu. I do have office hours on Tuesdays, or if that doesn't work for you, by appointment is just fine. Just get a hold of me and we can work something out. Have a great day. Bye.